Yesterday I talked about the recent advances in risk stratification for patients with amyloidosis, the new methods of imaging amyloid deposits in patients, and then some advances that are occurring in treatment, including drugs which will help us to clear the amyloid deposits in the body more quickly. The key in patients with amyloidosis is to work out how sick the patient is and what the risk stratification is. Traditionally, we've used markers of heart involvement in amyloidosis as markers for stratifying these patients. But lately, we've got other interesting markers such as von Willebrand's factor, which is a clotting factor. And very high levels of von Willebrand factors suggest that there is some toxicity to the endothelium lining the blood vessels. And this is a marker of poor prognosis. In patients who are treated, the von Willebrand factor levels will decrease. And this may be a marker of better outcomes. There's another marker called GDF15. This is a marker which is very well known to patients to physicians in cardiovascular diseases, and this is a marker of prognosis in amyloidosis. We also talked about the novel imaging agents which have been used for many years and which are licensed in Alzheimer's disease. These agents appear to be very specific and very sensitive for imaging amyloid in the heart. But more interestingly, we are also able to see amyloid deposits in soft tissues, in the gut, in the liver, in the spleen, something that we've never seen before with any other imaging agent. We had a brief slide about magnetic resonance cardiac imaging, which can tell us about the extent of amyloid deposits in the heart and also about the damage that the amyloid-forming proteins are leading in these deposits. Moving on to the treatment part of amyloidosis, we talked about how challenging it is to support these patients when they're very sick and very unwell, and what supportive measures are required, such as antiarrhythmic drugs, devices to stop their hearts from getting irregular heart rhythm, like implantable converters and defibrillators. We went through some of the chemotherapy aspects, which have shown that with our traditional bortezomib-based chemotherapies, we are able to get good responses in the patients, and these responses are very long-lasting. But we find that on an overall basis, we still find a number of patients die before they achieve the response. What we found was that even with very good responses to chemotherapy, not a lot of patients will improve their organ function, and hence there is a critical requirement for drugs which can remove the amyloid deposits or help the body to remove amyloid deposits. And these are immunotherapy drugs, antibodies which can bind to amyloid fibril protein or to other proteins which are present on the amyloid fibrils, and these will then activate macrophages. The macrophages will then target the amyloid deposits and help the body to clear them rapidly. We have got 3 different agents which are in different phases of clinical trials, and all of them show very good promise in treating amyloidosis. We hope that the results of these trials will be available maybe later on next year and the year after, and that promises to change how we manage these amyloid patients.